Diabetes is a common and potentially dangerous disease.
Diabetes is really a major health concern, and it's growing. So it's a major public health challenge, which might predispose people to complications like neuropathy, ulcers in the foot, and amputations.
But it's also very manageable.
Diabetes is not as unmanageable as it used to be. It has become very manageable with right tools, education, and commitment.
And later, learn about diabetes-related health challenges.
Anybody who has diagnosis of diabetes will at some point experience some sort of symptoms of neuropathy. It will happen.
Discover the battle to beat diabetes inside this edition of CTSI Discovery Radio. Welcome to CTSI Discovery Radio. I'm your host, Brian Belmer. CTSI Discovery Radio is brought to you by the Clinical and Translational Science Institute of Southeast Wisconsin. The CTSI is a consortium of researchers, doctors, scientists, and others representing 8 institutions, including the Medical College of Wisconsin, Milwaukee School of Engineering, Marquette University, the University of Wisconsin-Milwaukee, Children's Wisconsin, Froedtert Hospital, Versity Blood Center of Wisconsin, and the Zablocki VA Medical Center. The CTSI works collaboratively across all of our member institutions. Our mission is advancing health through research and discovery. An estimated 38 million, or 1 in 10, Americans are diagnosed with diabetes. And while the disease can be dangerous, even deadly, it's also manageable and treatable. On today's show, let's first discover what diabetes is and gain a better understanding of its common characteristics and its comorbidities. First, we hear from Dr. Srividya Kadambi, Senior Medical Director, Chief, and Professor, Department of Medicine, Division of Endocrinology at Froedtert and the Medical College of Wisconsin. Dr. Kadambi begins by sharing that diabetes is
a chronic health condition. Traditionally has been felt to be a condition where body struggles to regulate its blood sugars due to problems with insulin made by the pancreas. High blood sugars can result in a number of health problems if they are not managed properly.
Something important that isn't as readily associated with diabetes
is that it has a variety of things that result in this high blood sugar condition. So the conditions that cause diabetes also is part of diabetes pathophysiology. So again, it's a chronic condition manifested by blood sugars, but there's more to it.
A lot more to it. She explains which body parts are involved in diabetes, beginning with our pancreas.
So pancreas is an organ that produces insulin that helps regulate our blood sugars. In diabetes, a couple of things can happen. One is the pancreas itself is at fault and does not make enough insulin.
Or, conversely, another type of diabetes whereby
pancreas actually makes more insulin than normal, but that insulin that is made is not effective. What we call insulin resistance, so lack of appropriate amount of insulin as well as insulin resistance, both of them.
To this point, we've heard about insulin, but what exactly is it?
It's a peptide hormone or a protein hormone that is secreted by certain cells in pancreas. So what it does is it allows each of the cells to absorb glucose from the blood into itself and allows the cell to function. It doesn't matter if you have glucose in your circulation. If your cells cannot use it, it's not useful at all because that's where the energy comes from. So without normal insulin levels or improper function of insulin, blood sugar increases,
which can lead to one type of diabetes or another.
And high blood sugar can result in complications related to nerve damage, kidney damage, or vision damage. So those are the roles that insulin plays.
The lack of or resistance to insulin can negatively impact our body in other ways as well.
But the 3 most important parts of our body that actually need insulin to work glucose into their systems is liver, muscle tissue, and our fat tissue. Those are really big parts of our body: muscle, fat tissue, and the liver. And in insulin resistance, these are the three organs that cannot utilize sugar properly. And that's what results in significant rise in blood sugars because muscle is not absorbing, fat is not absorbing, and so on and so forth.
Next, we asked Dr. Kadambi, on the spectrum of diseases, how concerning is diabetes?
Diabetes is really a major health concern because, first of all, a lot of us have it, which is 1 in 10 Americans have overt or actually full-blown diabetes, and about 96 million Americans have prediabetes, and it's growing. So it's a major public health challenge. But it's not just blood sugars being high, which might predispose people to infection and such. It also portends other complications like vision loss, kidney problems, neuropathy, and then result in cardiovascular complications such as heart disease or what we call as peripheral vascular disease that may cause ulcers in the foot and amputations. So it is really, really a major risk factor for a number of health conditions and really needs to be addressed at a very early stage.
Who is most vulnerable to be impacted by this disease?
There is not a huge gender-based difference, although men might get it earlier because of weight and where the body fat is distributed. Men have central adiposity. But in general, the most common risk factors are obviously age. As you age, more people have diabetes. Those with family history of diabetes, it is significant genetic predisposition for this condition. Obesity is a significant risk factor. And there are some ethnic variations as well. Black, Hispanic, Native American, and Asian Americans are at a significant high risk compared to Caucasian population.
What are the different types of diabetes? Dr. Kadambi shares insights on each, beginning with type 1 diabetes.
Type 1 diabetes is an autoimmune diabetes. Our own body attacks the pancreatic beta cells, which produce insulin, and thereby stop making insulin. So these cells do not produce insulin or make it in such small amounts that it's practically a negligible amount.
Type 1 diabetes is an autoimmune disease.
But there is a genetic predisposition. Now, not everybody who develops type 1 diabetes has had a family member who has had type 1, but there is definitely, we know certain genotypes have predisposition. And we cannot pinpoint specific genes, but we know some HLA markers can be there.
As far as who commonly has type 1 diabetes,
it's typically diagnosed in children, young adults. However, we are seeing a lot more people that are diagnosed at any age. You can even be 70 and could be diagnosed with type 1 diabetes. So it's no longer called juvenile diabetes. That was the term that was used for a long time, like juvenile diabetes or childhood onset diabetes. So we don't see that anymore.
And research has revealed diabetes types can have subsets.
Often there is a variant of this type 1 diabetes called LADA, latent autoimmune diabetes in adults, where patients have this type 1 diabetes picture, but their pancreatic beta cells don't stop abruptly. So they kind of slowly go away. So there is a longer period during which it develops. So the type 1 diabetes could be this abrupt onset in children, or this LADA type where there is a lingering onset, like maybe it takes 1 year or so to develop, and it's still type 1 insulin deficient diabetes.
Another distinguishing factor of type 1 diabetes is a subcondition known as diabetic ketoacidosis, or DKA.
It's a very serious condition. Patients who have type 1 diabetes need to always have some amount of external insulin in their body. So if they miss their insulin shots, they go into this acidotic state called diabetic ketoacidosis, and that can be life-threatening and often requires hospital admission and IV insulin and things like that.
Then there's type 2 diabetes. What are its distinct characteristics?
Insulin resistance is its hallmark. Most of the patients with type 2 diabetes actually do have quite a bit of insulin. So it's not that pancreas is not making insulin. It is just not making enough for that particular person because insulin resistance is also variable. So there's that individual variability. So at what point do they need external insulin depends upon their insulin resistance levels.
And the individual's level of obesity.
Obesity is the major risk factor for type 2 diabetes. It is often said that 90% of type 2 diabetes disappears if you take care of obesity.
Which means, if there's any good news about type 2 diabetes, it's that type 2 can be reversible, or
you actually can prevent it. You can prevent it with healthy lifestyle changes. And if the obesity is the major cause, and if you take care of obesity, type 2 diabetes can go into remission, long-term remission.
But Dr. Kadambi cautions
it is also very strongly linked to genetics, even much more so than type 1 diabetes, and also a lot of lifestyle factors, sedentary behavior, obesity. It's much more common in adults. However, there's been alarming increase of type 2 diabetes in children due to increase in obesity in children lately.
Now, diabetes has always been considered a blood sugar diagnosis.
However, we have to understand that blood sugar rise is at the end of a number of years of pathology that's been happening in the body. So the time that your blood sugar goes up, it's really the point that insulin can no longer match the requirements. But the disease has started in childhood or early adulthood with obesity and insulin resistance.
So even before the development of blood sugar-related type 2 diabetes,
there are things that happen in your body that may not be reversible, particularly cardiovascular disease. That's why a lot of times patients get diagnosed with type 2 diabetes at the time of heart attack. But whatever it was causing type 2 diabetes is also causing a lot of other things.
Which is why there's been a shift to a more obesity-centric management of type 2 diabetes.
As opposed to glucose-centric, because they have other risk factors that go along with it, which is high cholesterol, high blood pressure, all of which together can cause heart attack. So I think management of these coexisting metabolic complications is extremely important, and paying attention to obesity is extremely important to prevent development of these complications.
There are a couple of other types of diabetes in addition to type 1 and type 2.
One is prediabetes, where the blood sugars haven't yet reached the level to be diagnosed as type 2 diabetes, but it's a warning sign. And again, similar to early type 2 diabetes, lifestyle changes can prevent progression to type 2. We often treat prediabetes as seriously as type 2 diabetes because the conditions that cause prediabetes and type 2 diabetes are identical, meaning lifestyle, genetics, and obesity.
Then there's gestational diabetes.
Now, this one develops during pregnancy in women, and it increases risk for type 2 diabetes later. The risk factors are almost identical to prediabetes and type 2 diabetes, so gestational diabetes should be treated very carefully after they deliver the child, even though the diabetes might go away, but it's a high risk for development of type 2 diabetes in future.
What are the symptoms of diabetes? Well, it's tricky because with type 2 diabetes,
the problem with type 2 diabetes is it's completely asymptomatic. Unless the blood sugars go so high, they're constantly running 300, 400, people actually do not feel anything. And often we have seen that when patients have heart attack, and that's the first time they had blood work, and okay, you know what, you have type 2 diabetes now. So often it can get diagnosed in routine blood testing and without symptoms.
However, if blood sugar levels are high enough for long enough, there will eventually be symptoms.
They may at that time feel increased fatigue because their cells are not able to use the glucose that's circulating in their blood, or they may go to bathroom a lot because blood sugar is not getting absorbed, so it just gets peed out. They may have increase in thirst, and because they're losing sugar in the urine, they may have weight loss, and sometimes blurred vision because our eye lens can react to the high blood sugars.
These same symptoms are common for people with type 1 diabetes, just more readily because
type 1, as I mentioned, is somewhat more abrupt and more severe lack of insulin. So these type 1 patients actually feel these symptoms a lot more. So increased thirst, frequent urination, fatigue, some weight loss, and blurred vision.
What are common treatments for diabetes? For type 1 diabetes,
obviously, because of insulin deficiency, you do insulin. Even for patients with type 1, lifestyle interventions are extremely important. Type 1 diabetes patients follow the carb-restricted diet, don't gain excessive weight, and then exercise. Because even patients with type 1, if they develop obesity, they can become insulin resistant and require more and more insulin.
Patients with type 2 diabetes have a few more options.
We may not need to start insulin right away. Again, lifestyle interventions, diet, exercise, and obesity prevention.
Then there are medications to treat type 2.
There are about 6 classes of drugs that can be used for management of type 2 diabetes. Metformin is one of the drugs, so it's a pill. And then there are sulfonylureas that increases insulin production from your pancreas. Then there are drugs that are going by the names Invokana or Jardiance. They make you pee out sugar, decreasing blood sugars.
And now, injectable medications.
And they're called GLP receptor agonists, Ozempic or Mounjaro or Victoza. So these are shots.
So, proper care of one's diabetes can result in having a good quality of life.
For type 1 diabetes, lifestyle modification, taking insulin on time, getting all the preventative care. For type 2 diabetes, you can really put patients into serious remission, even to the point that they do not require any medication. So definitely can be done.
On the other hand, uncontrolled diabetes can be devastating.
Patients with type 2 diabetes are at higher risk for a poor quality of life because it predisposes patients to cardiovascular disease, peripheral vascular disease, chronic kidney disease, vision problems, and problems associated with neuropathy, foot ulcers or amputations, and things like that. So there are definitely complications of uncontrolled diabetes.
Fortunately, ongoing research is discovering ways to better control and care for the disease, including improved devices,
which is continuous glucose monitors. This was a big issue to ask young people to check their blood sugar multiple times and dose their insulin. Now, the second major advance is the insulin pump. It delivers insulin continuously, almost mimics your own pancreas. But now these two are talking to each other. The continuous glucose monitor talks to the pump and adjusts the insulin delivery for management of type 1 diabetes and some type 2.
And hopefully, future discoveries to battle and beat diabetes.
Diabetes is not as unmanageable as it used to be. It has become very manageable with right tools, education, and commitment. Living well with diabetes is totally achievable, and there is a huge amount of effort underway to make this possible.
Next, we discover medical issues patients are prone to experiencing as a result of their diabetes. Specifically, we'll look at neuropathy conditions of the foot. Dr. Brian Fisher is a podiatrist and foot and ankle surgeon at Froedtert and the Medical College of Wisconsin, who begins by explaining his area of expertise, podiatry.
Podiatry really has become almost like the primary care provider from a lower extremity perspective. So we really address all the different conditions, whether it's diabetes, dermatological conditions, infections, but then also trauma, sports medicine. So pretty much anything you can imagine that has to do with the foot or ankle, we are your people.
That includes diabetes-related foot conditions.
Every patient who is diabetic will have some sort of potential complications or conditions as a result of their diabetes. It's not a matter of if these things are going to happen, it's a matter of when they're going to happen. The myriad of different conditions that can occur are going to rear their head at some point. 100%. Everybody that has diabetes, at some point, they will have a diabetic-related foot issue.
There are many diabetes-related foot conditions, and Dr. Fisher shares his expert insights on some of them, beginning with neuropathy, or nerve damage.
That can really present in a lot of different ways. For most people, burning, tingling, electrical shock type signaling that they will feel in their feet. And then there's also the component of loss of sensation that can really present with neuropathy.
The danger that neuropathy presents.
It is almost the starting point for a lot of the other issues that we deal with. Because when people lose that ability to maybe sense things as good as they should be able to, that opens the door for a lot of the other complications people will present with.
Another diabetic-related condition is arthropathy, or joint damage.
Fundamentally, diabetes isn't going to give you your traditional osteoarthritis, but there are a string of conditions. One that somebody that has an end-stage neuropathy end up getting a small trauma that can cause a major degenerative effect on their foot where joints can really start to become deteriorated because of their diabetes as well.
Then there's vasculopathy, or blood vessel damage.
Outside of neuropathy, what I see in my practice, vasculopathies are probably the biggest concern. One thing about a foot that has good blood flow is it tends to heal well.
But the opposite is true as well, which means
the effects of diabetes in regards to the inflammatory process and the calcification that can occur both in your arteries and your veins make, at times, critical limb-threatening situations for patients, a common thing that we see as well.
And there are other diabetes-related foot complications, including
dermatological manifestations. The skin can become very dry and start to peel. They're a little bit more susceptible to developing things like athlete's foot or a fungal infection of the toenails. You also have patients who their nails become very thick, very brittle, as a result of the disease process as well.
Fortunately, some patients come in even before being diagnosed with one of these diabetic complications.
People will come in maybe because of something they read or they hear about neuropathy, and then they say, wow, I think I might have this problem as well. So there's a lot of people who are starting to take the initiative, causing an increase of coming in sooner than later than what they used to.
Which is the most serious type of diabetes-related foot condition?
Inherently, neuropathy and vasculopathies are probably the most dangerous, mainly because of the fact that you can have a patient who has a very subtle trauma that they don't feel because of their neuropathy, and then they don't have the ability to heal that minor trauma because of their vascular issues.
This speaks directly to
the unfortunate part about these conditions. They tend to snowball together, and the disease process of diabetes doesn't normally handpick one of these body systems that it affects. It tends to affect all of them.
In his practice, Dr. Fisher focuses on diabetic-related neuropathy, and he gives insights on different types. First, peripheral neuropathy.
Peripheral neuropathy really pertains to affecting your distal components of your extremities. Traditionally, it affects both of the extremities in a similar way. So it's bilateral, it's symmetrical. Traditionally, it has what is called a stocking and glove manifestation, where people will start to notice more of the toes and the ball of the foot or the fingertips into the palm of the hands present a peripheral neuropathy.
What are symptoms of peripheral neuropathy?
Every patient has their very own presentation words like, I have a burning sensation, an electrical shock sensation, tingling in my feet. So there's kind of this altered sensation just in general people will present with.
Then there are subsections of peripheral neuropathy, such as autonomic neuropathy.
Autonomic neuropathy really has to do with kind of your body's ability to thermoregulate itself. So somebody relating their feet feel on fire or super hot or super cold. Some patients will present with feet that are always very sweaty. Other patients that they're always super dry.
Sensory neuropathy.
That will be people that lose the ability to feel certain areas of their foot, or they have trauma or an open wound and they don't even know it because they lose that sensation.
And motor neuropathy.
Peripheral neuropathies can affect the very small, fine muscles that build within the bulk of the foot and control the fine motor movement. Motor neuropathy, those fine, small muscles are the first ones to actually be affected. The bulk muscle mass of the foot becomes very weak, and you start to get progressive deformities and lose static stability.
Next is focal neuropathy.
Focal neuropathy is something that will present in a very isolated location. For instance, in the foot, there's something that's called a tarsal tunnel syndrome, which is an impingement of the main nerve that provides the supply for the bottom of the foot. People will have a very distinct area of one foot traditionally that will present with it, and it's along the root of one of those nerves compared to both lower extremities in a very predictable and symmetrical way.
And finally, proximal neuropathy.
Proximal means closer to the core of the body compared to distal, which is further away. So a neuropathy can work its way up. You can also have some more centrally located lesions, sometimes some low back issues near the spinal column can cause a more proximal neuropathy, which presents not just in the extremity, but can present on the entire leg or something like that.
Dr. Fisher says, in assessing a diabetic patient's neuropathy,
the first thing you need to do is take a step back and try to determine the why. And that can be really difficult because unfortunately there is a condition that is called idiopathic peripheral neuropathy. You have all of the symptoms and the presentation of neuropathy, but yet we can't pinpoint a reason as to why the nerves are malfunctioning the way they are.
So, although you can't stop a patient's neuropathy from happening in the first place,
you can control the disease process, blood sugars, and overall health to try to make the symptoms less acute and also give yourself the best chance of preventing those symptoms from worsening.
Still, for those with an idiopathic peripheral neuropathy,
it's really hard to stop the disease process because you don't know why it's happening in the first place. So although a specific neuropathy might not dictate only patients with diabetes get this type of neuropathy, the process of how your disease evolves will be highly dependent on the cause behind it.
remember, It's not a matter of if someone with diabetes might get neuropathy related to their disease.
Anybody who has diagnosis of diabetes will at some point experience some sort of symptoms of neuropathy. If you're working through the disease process long enough, it will happen. Regardless of what type of diabetes you have, yeah, it's going to happen.
When it does, Dr. Fisher and others can help manage expectations.
Anybody that tells you that there is a cure for neuropathy is maybe creating a little bit of a pipe dream, because to this point, there's really no cure.
But it is treatable to an extent with medications.
There are some vitamin complexes, like a vitamin B complex, that can work for some people. Medications that provide some relief. The way those medications work is they're blocking those pain signals from registering in the brain, so it doesn't bother you as much.
Lifestyle modifications.
Blood sugar control, trying to live a healthier lifestyle with diet, exercise, that will decrease the intensity of the symptoms that you have and prevent it from getting worse.
And emerging treatments like
spinal cord stimulation, which is a treatment option for individuals who have low back issues and that kind of stuff. And they get an implantable spinal cord stimulator in the low back. It can actually help take away some of the really intense burning, tingling type sensation. That's probably the latest and the greatest treatment option right now.
But any treatment is better than none, because left untreated,
progressively worsening neuropathy that's not being addressed or the patient doesn't have close follow-up is a patient that goes from a mild risk to a moderate risk to a very high risk, and that can be quite quick. More often than not, you're treating them reactively instead of proactively.
And the consequences can be severe, because oftentimes
that leads to a wound that can lead to infection. And unfortunately, in some circumstances, infection leads to loss of parts or all of the limb, so it leads to amputation.
Consequences that can impact quality of life or life itself.
Severely. I mean, it can kill you. Neuropathy will not kill you, but it can lead to complications that can lead to amputation and or potentially death. So it can be absolutely devastating. It really can be.
Therefore, the idea is to be proactive.
Patient education is very important before they even have a problem. At some point, they may develop those symptoms, but we're going to really mitigate the risk associated with those symptoms.
Once you know what to look for,
if you see something, say something, right? Because you can prevent bad things from happening if you act swiftly.
And there are organizations that can provide resources and insights.
The American Diabetes Association and the American Podiatric Medical Association, on their websites, they have a ton of patient information.
For anyone dealing with diabetic-related neuropathy, Dr. Fisher says, be informed.
There isn't a silver bullet for neuropathy, and a lot of times people were saying there's not much you can do for neuropathy. But again, the world is changing in regards to the treatment options, and there are so many different things that can hopefully give patients relief.
Be vigilant.
Very simplistically, check your feet on a daily basis. If you see something that's different, you got to say something.
And be hopeful.
There is hope. Just because you've been told previously there's nothing that can be done, I would highly challenge that comment, because there's things today we can offer patients that we couldn't have offered 5 years ago.
That's all the time we have for this edition of CTSI Discovery Radio. As always, thanks to each of our guests for appearing on today's show. Dr. Sridivya Kadambi and Dr. Brian Fisher. I hope you've discovered something by listening to today's show. And I'm doubly hopeful you'll join us again next time. CTSI Discovery Radio airs the third Friday of every month. Join us for each episode. On behalf of the Clinical and Translational Science Institute of Southeast Wisconsin and all of our affiliate partners and members, I'm Brian Belmer, wishing you happier, healthier days ahead. For more information about research or to listen to the podcast of this or any of our shows on demand, please visit our website at ctsi.mcw.edu. CTSI Discovery Radio is written, produced, and hosted by Brian Belmer in collaboration with WMSE Radio. The CTSI and this program are under the direction of Dr. Reza Shakir.